Welcome to the second lecture on sleep test interpretation. The first lecture covered normal sleep. This lecture will demonstrate a clear-cut case of OSA, or obstructive sleep apnea. Most of the discussion will be from the graphic summary. There are many features of this study whose timing and relation to other events are important. We see a very short sleep onset. We expect the numerical data to show a short sleep latency consistent with sleep deprivation. I see three stages to this study. During this first stage, there is no REM sleep. Non-REM sleep is fragmented, particularly at the end of this stage. There are a lot of respiratory events. Most of these events are hypopneas. Oxygen saturation is not doing a lot during this stage, but it is borderline low all the time. The patient is awake during the second stage of the study. He or she is unable to sleep. Note that the oxygen sensor is coming off while the patient is awake. These are artifacts and do not represent desaturations. The final stage of the study demonstrates REM sleep. The REM sleep is fragmented, but not as bad as sleep was fragmented during the first stage. Non-REM sleep proceeds without interruption. Note the clustering events during REM sleep. There are some events during non-REM sleep, but there are many more events during REM sleep. We see more obstructive events rather than only hypopneas. It is very common to see more events and worse interruption of sleep during REM sleep than during non-REM sleep. Note that oxygen saturation is much worse during REM sleep. Seeing more events and lower oxygen saturation during stage REM is a very common pattern. This patient was supine during the entire study. Body position did not appear to play a role. Let's see some numbers. The sleep efficiency is low. Normal is around 85%. Normal in the elderly can be as low as 80%, but this number is clearly abnormal. Much of the wake time was during that prolonged second stage, so sleep efficiency was otherwise pretty good. The sleep latency is very low. Normal is 15 to 24. Anything less than 10 is consistent with sleep deprivation. The REM latency is high. Some of this abnormality is due to the prolonged period of being awake. Let's attach some numbers to the events. There were 30 obstructive apneas. There were 130 hypopneas. There were 160 total respiratory events. The apnea-hypopnea index was 34.2. This is well above Medicare guidelines for CPAP therapy. This patient will qualify for CPAP testing and treatment. Note that the REM AHI is higher still. This is a very high AHI and is very disruptive to sleep. It is doubtful that this patient has any effective REM sleep with these kind of numbers. This would account for the very short sleep latency. Let's look at the oxygen numbers. The mean saturation is marginal at 90.3. This tells us that there will be significant time with hypoxemia. The minimum saturation is very low at 65. The question is how much time is spent at low levels. There are 47 minutes of significant hypoxemia. Although this patient qualifies for nocturnal oxygen therapy, oxygen should not be prescribed until after CPAP is tested. It is quite possible that CPAP will eliminate the need for oxygen. Let's summarize our findings. The sleep quality is poor. Sleep efficiency is low, and the sleep latency is consistent with sleep deprivation. We have evidence for sleep pathology. The AHI is very high at 34. This meets the criteria for a diagnosis of obstructive sleep apnea. The AHI of 34 also meets Medicare guidelines for CPAP titration and therapy. This patient should have a CPAP titration. If for some reason CPAP cannot be tolerated by the patient, then the patient would qualify for supplemental oxygen. Oxygen would be better than no therapy, but oxygen would be a very poor second choice to the preferred treatment with CPAP. This concludes Lecture 2. In Lecture 3, we will look at a CPAP titration study.